Okay, so hi everybody over there on the table. My name is Mia. I'm an eating disorder dietitian. It's good to meet y'all. And I can finally hear everybody, so that's fantastic. So I hear that I'm on an iPad. I do have like a little presentation that kind of just goes along with what I'll be talking about, but y'all can pass me around if you want. You can look at the slides later. What year are we all in? Are we all dietetic students?
All dietetics mostly.
Okay.
We have med.
Okay, cool. I am 6 months into my RD career, so I just finished my internship not too long ago. Um, Let me share my screen with you guys and we'll get into it. Cool. Okay. Can y'all see my little presentation? It probably looks small on the iPad, but okay. So, like I said, my name is Mia Kolb. I am a fresh RD, and I work in eating disorders. So I'm coming to you from Eugene, Oregon. We're like 2 hours south of Portland. If you guys are familiar with the University of Oregon, that's in Eugene. Um, so my friend Aline asked me to present to you guys kind of my journey towards becoming an eating disorder dietitian, what that looked like as far as like undergrad, applying for internships, what my internship looked like and all that jazz. So I'm really happy to be talking to you all today because I had to really seek out dietitians when I was in my undergrad program. So let's see. We'll start here. So I went to the University of Arizona for my undergrad. I did it completely remote. I've actually never like set foot on the University of Arizona campus. My now husband and I built a camper van in 2021 and lived in it full time for my junior and senior year of college, traveling the United States and finishing my degree. So you can kind of see probably little pictures of my van there. Um, let's see. While I was in my undergrad, I interned with Nurtured Nutrition Therapy, which is where I met Aline. And this is a like group practice for eating disorders, and it was just a group practice for dietitians. And this was really like an invaluable experience for me because I really wanted to learn from an eating disorder dietitian to make sure that I was, on the right track, that what I thought I wanted to do in my career actually aligned. And she really, really mentored me, and this really solidified my path. So I spent a year and a half writing blogs about eating disorders for her group practice website. And she is still someone that, I consider a mentor. And so I really, I went out of my way to, like I said, find dietitians who were working in the eating disorder space because it's not a niche that a lot of, RDs work in. And I really wanted to make sure that like what I thought really aligned with my goals. And so I really encourage y'all when you're in your undergrad to seek out dietitians who have been in their careers, who are in careers or niches in the field that you think, you would like to work in one day yourself. It was really, like I said, really invaluable. So that was kind of my undergrad journey. And starting around like junior year, end of junior year, beginning of senior year, I started to look into internships. So depending on what year you guys are all in, you guys have probably already started thinking about this yourselves. For me, my priorities were really like having a cohort and having fellow interns that I could lean on during the internship process. And so I was thinking, do I want to do a distance internship what is a combined internship? What is a future education model? All of these like acronyms that, you know, the AND throws out. It was kind of, this whole process was a big mystery to me. And so I really prioritized like having interns that I could rely on and like go through the process with together. Having the option to do a rotation in eating disorders, so that I could gain experience and be more attractive to future employers. And then also like not having to secure my rotation sites on my own. With some internships, you know, some internships will ask you to, you know, have signed agreements with your rotation sites before you even apply to their internship and get in. Some will have you do it after you've already gotten into the internship. Some will, you know, find all the rotation sites for you. I really didn't want to have to start from scratch and like reach out to a bunch of hospitals. So it was really important to me that the internship I chose at least set up a couple of those, namely the clinical rotation. A lot of, you know, the RDs that I know now, the interns that I know from other programs, they had a lot of trouble finding a clinical rotation because a lot of hospitals have contracts with dietitian employers. So one of those being like Sodexo or Aramark, they're contracted with hospitals, and so they wouldn't take interns from other internships. So it's a big pain in the butt. So I didn't want to have to do that. And I also didn't want to finish with a huge amount of student loan debt. And that's something to think about when you're looking at programs that are 2 years or some are 1 year. Having to pay for 2 years can, depending on your situation, my situation was I was using loans. So I didn't want to finish with a huge amount of debt, especially when we look at the income to debt ratio once we graduate. That was really important to me. That was definitely a priority, that I wasn't, you know, finishing and starting my career with a bunch of debt. So I also wanted to finish really quickly. So there are some programs, like I said, that'll be 12 months where you can get the master's and the internship in 12 months. There will be some that are 2 years. There will be some that are 3 years. And then I really wanted an internship that really prepared me for the CDR exam, that like gave me study tools, that had study groups, that, you know, prioritized rotation assignments and schoolwork around really preparing you for the CDR. So that's what I kind of went in with. I participated in the 2023 match, which I think was either the last one or almost the last match, which I'm sure y'all have heard about it. Thankfully, they got rid of it. But very similarly to med students, you would match with a program. You'd be put into an algorithm where, you know, schools would rank you, you would rank schools, etc. So that was really daunting. I'm really glad you guys don't have to go through that anymore. This is a really great resource. The AND applicant guide to supervised practices has every single internship in the United States listed with their tuition, if they disclose it, where, you know, all kinds of information. And I probably poured through every single page of that, looking at every single internship in the United States. So you can find that on the AND website. They put it out every year. And I really recommend looking through there, because finding internships, I feel like my undergrad didn't give me a lot of resources. So highly recommend. I applied to 4 programs in the match, which I do not recommend. And one that was not part of the match. So that was the Sodexo program. I would suggest only really applying to 2 to 4. The nice thing about, you know, you guys in your position right now being in undergrad is that dietitians are in demand. And because of the new master's requirement, there are not enough dietitians. There are not enough people going towards the master's and going towards the RD credential now with the new master's requirement. So Employers are hiring and there's just not enough of us. So you guys are in a really good standing. You are in demand. So I would really only suggest applying to 2 to 4. Don't like break the bank with the application fees, like I did. You guys will get in somewhere, if not everywhere you apply. So I know y'all are smart. Dietitian to be's are definitely type A, definitely super intelligent. So y'all will be totally fine. Don't get anxious about it. Easier said than done, but you guys will be good. I got into my top choice in the match, which was one of 2 programs in the United States that emphasizes eating disorders, which is Simmons University. It's a female faculty, predominantly female student body, like STEM university in Boston that works with Tufts Hospital. So I got into that, which was great and awesome. And then I also got into the Sodexo program, which was not part of the match. So I ended up actually choosing the Sodexo University of Rhode Island combined MSDI program. I turned down my top choice because it was 2 years. It was way more expensive. If I hadn't have done that, I would still be in my master's program and my internship right now, but now I'm 6 months into my career. So ultimately, employers don't really care where you go as long as you've got that RD credential behind your name. So I finished with less debt, and that's what's important to me. So the University of Rhode Island and Sodexo MSDI. Sodexo is the largest private employer of dietitians in the country. They, like I said, have a lot of contracts with hospitals across the country. And so they actually set up your clinical rotation, your food service management rotation, and your patient services rotation for you. They match you to a hospital in an area of your choosing that they are already contracted with. So you'll learn from Sodexo dietitians. So I think that's a really cool part of the Sodexo URI program. These are, you guys probably can't see these pictures, but these are pictures of some of my friends in the cohort, some things I did, me in the hospital. So I really liked this program because, let me move my little dude over here. Okay. I really like this program. It was a future education model. There's my cohort. There's about, 50 of us. It was 12 months total. The internship hours and the master's classes were completed simultaneously. So it was completely remote. I would finish my, 32 hours a week at the hospital or whatever rotation I was in at the time, and do my classwork after getting home. And it was only 8 months of internship. So 32 hours a week, 1,200 hours. And it was completely distance, completely remote, completely online. And I'm so glad to be done, and you guys will be done soon. So if y'all have heard of the Sodexo rotation, if not, I just put some information in here if you guys are interested in it. I will say Sodexo internship really tries to recruit their interns. So if you guys are interested in clinical, interested in pediatrics, NICU, oncology, stuff like that, Sodexo will try and hire you after finishing your internship. They really try and recruit their interns. So that's something that may be attractive to some of y'all. It was not to me because I had no interest working in clinical. I wanted to work in eating disorders. And so they were also very supportive of that. But just an option for you guys. This kind of lays out, if you all want to look at this later, how many weeks you spend in each rotation, where in the United States they place interns. So you get to, put in your top 3 choices wherever, and you get placed around the country. And then they have a specialty rotation, which not all internships do, where you can do a specialty rotation in an area of your choice, which allowed me to do mine in eating disorders. So another cool thing about this internship. So these are the rotations I did. I actually got placed in Colorado. So while my husband and I were traveling the country in the van, Colorado was one of the states that we were like, I could live there for a second. So I chose Colorado and got to live there for a year, which was pretty cool. I did my clinical and food service management rotation at UC Health Memorial Central Hospital, which was a Trauma One center. So I got to see a lot of cool things, and work with a lot of interesting cases and disease states. Got to sit in on a surgery, got to watch a barium swallow, which was really cool. Got to do a lot of things, see tubes placed, all kinds of stuff. So that was a really cool experience. I love clinical. I just don't want to do it full time. And then I did my community rotation at this place called Inspire Recovery, which was an LGBTQIA and substance use recovery center, which was completely remote. And that was a cool experience. That was a short rotation. And then my specialty rotation was at the Eating Recovery Center in Denver, Colorado. So I just included some pictures of what that looks like. So the Eating Recovery Center is Denver in particular is really the epicenter of eating disorder treatment. I don't know if any of y'all in that room are interested in eating disorders, but this is considered like the place to get treatment in the United States, because they have the acute center for eating disorders, which takes extreme cases from people outside the US and all over the US that get flown to acute for survivorship eating disorder treatment. So we're talking about patients who organs are shutting down, and they are too extreme of a case to be taken anywhere else. So patients who go to acute then step down in level of care, and I'll kind of talk about that a little bit more, but step down in level of care after medical stabilization. So they're being tube fed, they're getting fluids, they're generally at acute for a couple of months, weight restoring, and they will step down to the Eating Recovery Center in Denver. So I got to work in the adult inpatient facility, the residential facility, and the partial hospitalization facility, and also the adolescent inpatient and residential facilities. So two different populations, saw a lot of extreme cases. It was, I mean, such an important rotation for me. So you'll see in these tiny little pictures, the larger building is their inpatient and residential facility where, they receive 24-hour care. It is a locked-in facility. And I also included a bathroom photo, which I just think is interesting. You'll see kind of the mirrors in the bathroom photo. They are actually fun mirrors. So like in a fun house where they're like warped. They do this to discourage clients from body checking, and to help with body dysmorphia. They're kind of controversial. I think that they can probably lead to more body dysmorphia, but just something unique to eating disorder treatment. And then we have like a test kitchen where we did group cooking class, all kinds of stuff, group rooms. So I'll kind of get into my journey towards becoming an eating disorder dietitian after my internship. So I completed my internship May of last year. I then got my first RD job in July. I had not graduated with my master's yet when I got hired. I graduated a month later, and then contingent upon my hiring, I had to pass the CDR exam within 3 months of my hire date. So I passed the exam in November, and I had already been working as a dietitian for about 2.5, 3 months. So I don't think that's a really unique situation. I think a lot of people get their first job before graduating, before getting their RD credential. I was nervous. I was like, no one's gonna hire me. I don't have, my RD credential yet. I haven't passed the exam. I need to study. I haven't even finished my master's yet. And like I said, we're in demand. So it was actually not hard. Y'all can get a job secured before you're done with your internship, before you're done with your MS before you've taken your exam. So I'd really encourage even just to like put your feelers out there wherever you live and wherever you want to end up working. Even just to get the conversation started, like, hey, I'm going to be finished in a couple of months and I'm really interested in working with you guys. So don't be afraid to send your resume out before you're done with all this stuff. So I ended up securing a job at Montanito, which is an eating disorder treatment center that can be found in most states in the United States. I work at the Eating Disorder Center of Eugene, which is the partial hospitalization and intensive outpatient levels of care, which are those 3 photos at the top. I also work at Rain Rock, which is our residential facility. So clients live there full time, anywhere from 30 days to 4 months. And that is on the McKenzie River here in Eugene, and it's very beautiful. And kind of out in the middle of nowhere, very serene, really gorgeous place to work. So I spend most of my time at the day treatment facility, which is what we call it for PHP and IOP levels of care. And then I go out to the residential facility once a week. I am the main dietitian at the day treatment center. So we work with any, eating disorder diagnosis that you can think of. We see clients with, anorexia nervosa, which has 2 subtypes, restricting type and then binge purge type. We also see clients with atypical anorexia nervosa, which is clients with anorexia, but may still be within the normal weight range. We also see clients with bulimia nervosa, which the subtype is binge purge via either a misuse of laxatives and or diuretics, purging via excessive exercise, purging via self-induced vomiting, and misuse of medications for weight manipulation. We also see clients with binge eating disorder. So binge eating disorder is diagnosed when there's no other compensatory behaviors. So like the purging after a binge, excessive exercise after a binge, those wouldn't be part of binge eating disorder. So I think a lot of people don't know that delineation. We also see clients with orthorexia, which is anorexia nervosa with rigid food ideals. So a lot of, preoccupation and obsessiveness with pure food, clean food, obsessive, reading of like ingredients and food labels, things like that. So that kind of differentiates anorexia versus orthorexia. We also see clients with ARFID, which is a newer diagnosis. It was added to the DSM-5, I think about 10 years ago, which we see often coexists with autism spectrum disorder. So ARFID is avoidant restrictive food intake disorder. So there are 3 subtypes. We have selective food aversions, which often have to do with like sensory overwhelm, whether it's like the touch of food, the smell of certain types of food, the taste of certain types of food, the textural feel of foods, and sometimes even the look of foods. So selective food aversion. We also have another subtype, the fear of consequence. So typically either a fear of choking or of vomiting. Sometimes we see this in clients who have a history of being tube fed, where they have a traumatic tube feeding occurrence, and this can turn into a fear of consequence, ARFID diagnosis, where they feel like they're choking because of that experience of getting a tube feed. So we see this sometimes in the medical population. Sometimes we see this in children who get tube fed when they're young kids. And it's a really interesting subtype. And then we have a lack of interest in food, ARFID diagnosis. And those are the 3 subtypes. We also treat clients with OSFED, which is other specified feeding or eating disorder. This diagnosis is given when, looking at the DSM-5 criteria for eating disorder, they don't meet all of the criteria for one certain type of eating disorder. And so this OSFED diagnosis is kind of an umbrella. They have characteristics of multiple disorders. And that can be like an atypical anorexia nervosa, a subthreshold bulimia diagnosis, a subthreshold binge eating disorder diagnosis, a purely like purging disorder, and also night eating syndrome. And then lastly, we also treat clients who are struggling with diabulimia, which is a misuse, underuse, or manipulation of insulin doses in either type 1 or type 2 diabetics to either lose weight or control body shape. That one is, we don't see very often, but we do see clients with one more predominant eating disorder with also like the manipulation or misuse or self-judgment regarding insulin and diabetes diagnosis. So definitely an interesting population. So when I talk about levels of care, this is what I mean. And I understand I'm on an iPad, so I'll kind of read it out. But eating disorder treatment at its highest level starts at inpatient. So this is 24-hour care. This is medical stabilization. We're refeeding clients. We're trying to weight restore as quickly as we can because their organs are shutting down. They're having extreme, medical complications from their eating disorder. So typically we're doing enteral nutrition. We're watching for refeeding syndrome. Typically their BMI is 17 or lower. For a lot of inpatient facilities, the BMI has to be 15 or lower. So just to put that into context. And then they step down to level of care to residential. So again, this is still 24-hour care, but they're able to participate in treatment. They're not so malnourished. They are more cognizant, more cooperative. So they are able to participate in treatment, meaning they can go to 3 groups a day. They're ambulatory. They can walk on their own. They can participate in individual therapy with their therapist, individual therapy with their dietitian. And then they get to do 6 meal, so 3 meal and 3 snack exposures per day. And we call them exposures or nutrition exposure therapy because each meal and snack is really a therapeutic opportunity and an exposure to fear foods, etc., fear portions, I mean, you name it. So that's residential level of care. And then they get to step down from there to partial hospitalization, which is outpatient. It's 6 hours a day, 3 groups, individual therapy still, but now they're only getting supported 3 supported meal and snack exposures per day. So here at the Eating Disorder Center of Eugene, we do supported AM snack, lunch, and PM snack. And then from there, they get to step down to intensive outpatient, which is really preparing for outpatient life. It's really kind of like a bridge to outpatient life. It's only 3 hours a day. They do 2 groups, and they're meeting with outpatient providers. So we help them secure an outpatient dietitian and an outpatient therapist, while still meeting with them here in person. And so we really collaborate as a team, and make sure that transition to a completely outpatient life is fully supported and that everyone's kind of on the same page. So we do both PHP and IOP here where I am right now in my therapy room. So this is, I kind of wanted to lay out what does being an eating disorder dietitian really mean? I think that especially like in my undergrad and in my master's program and, other interns, other dietitians I know, we're not taught about eating disorders really outside of like maybe one class if you're lucky, maybe one lecture if you're lucky. A lot of dietitians hear eating disorders and they're like, I don't want to touch that. And I get it because you don't want to say the wrong thing. You don't really know how to treat it because we're not taught how to treat it in our DPD programs. Um, and so I think it's really important to like talk about one, that it's not so scary, and two, like a lot of what we do for medical nutrition therapy is really what we do for eating disorders. We're just um, we're just looking at it more from like a medical standpoint, but also more of like a holistic standpoint. So we're looking at our relationship with food and body, right? And how do we talk about those things when we don't have, like counseling experience, mental health work experience, stuff like that. So I get why it's scary. We're very like science brained. Um, so I wanted to kind of give you a full scope of like what it's like to be a dietitian in eating disorders. I think I think really the basis of it is we're helping people heal their relationship with food and their body. A lot of dietitians, a lot of RD to Bs get into dietetics because of our own struggles with disordered eating or body image or food judgments. And so I think that we all know a lot more about this than we think. Um, so with new admits, um, we are conducting an initial assessment within 48 hours. So we're ascertaining the history of their illness, their eating patterns, their weight history, like their usual highest, lowest, and weight at the start of their eating disorder. Um, what really led them to seek care. And then we're also trying to really get a full picture of like their eating disorder behaviors, such as binge frequency, purge frequency, restriction of calories. Are we calorie counting? Are we checking ingredients? Are we fearful of ingredients? What ingredients are you fearful of? What foods are your fear foods? What are your acceptable foods? All kinds of stuff like that. Like, things that we may not think about unless we work in eating disorders is also like, do you have history of like regurgitation or rumination, chewing and spitting so that it looks like you're eating food? What are your exercise behaviors? Are they compulsive? Are they compensatory? Do you exercise to make up for food intake? Um, we see a lot of competitive athletes. So we're trying to ascertain like type and intensity of exercise, and like really what the benefits of movement are for them. What is their relationship with movement? And how can we work with them to establish kind of like a joyful movement relationship with movement? Um, and typically, like at those levels of care that I talked about, we're not doing any movement. We're typically weight restoring, right? And if we're not eating enough, right? If we're not eating enough to support movement, then we're not moving right now. We're also, looking at like their refeeding risk. If they have any food allergies, because we want to notify the team on day of admission if there's food allergies. We also get, a lot of clients who are vegetarian, vegan, gluten-free, lactose intolerant as a way to restrict. And so we're trying to, really be investigators and figure out, okay, do we have a long history, like predating the eating disorder, for being vegan? Like, did you grow up in a vegan household, or are you being vegan because this is another way for you to control food and restrict food? And so we're really trying to figure that out with clients. And then we're also doing growth charts. So this is something that wasn't taught to me in my DPD or my master's program, was how to read growth charts and how to really figure out the trajectory of growth, whether they're in like the 75th percentile or the 55th percentile, and like where should their weight be if they hadn't had their eating disorder. And so we're getting growth charts from pediatricians for people 30 years old or younger, really, in order for us to make really informed target weights for weight restoration. And then lastly, we're initiating meal plans. So here at Montanito, we don't talk about numbers. So that is calorie numbers and weight numbers. we really want to decentralize numbers in our clients' lives, especially because it's very common for clients to have a preoccupation with weight numbers, calorie numbers, and so we don't discuss numbers at all. And you could probably be thinking, well, how do you not talk about numbers with clients or patients? When we're talking about like weight restoration, we'll go like, oh, you're restoring in the right direction. You know, you're right on target for appropriate weekly restoration. We're not going, okay, you're 145 pounds right now, and I need you to gain 2 pounds this week. We're not talking like that. They are not aware of the calories that they're eating per day, unless they're, you know, of course, engaging in calorie counting. We build our meal plans according to letters and colors. And so our meals will be like A, B, and C, and our snacks will be green, teal, pink, and navy. And so those differentiate calories that we know on our end, and on their end, it just looks like different portions. So that's how we set up our meal plans. So once our clients are established here at Montanito, it looks different. Like, for example, at the Eating Recovery Center, I was meeting with clients twice a week. Here, we just meet with clients once a week for one-on-one nutrition sessions. And then at residential, we do cooking group, we do nutrition group, and we do lunch outing, and those are the dietitian responsibilities. At PHP and IOP level of care, day treatment, we do nutrition group, meal planning group, lunch inning, and grocery outing. So a lot of clients have, you know, fear around eating out, and so we'll do a lunch inning or a lunch outing to expose them to restaurant food and eating food that they didn't prepare themselves, and therefore they don't know exactly what's in it. They don't know exactly how many calories there are. They don't know how it was prepared, whether there's oil or not oil, all of those things, all of the really taking away the control, right? So we're doing that. And then a lot of clients don't have experience with cooking food, preparing food, meal planning, grocery shopping. And so in the day treatment facility, we're really trying to build those skills in a way where they still have their support, they still have their treatment team, and are able to do these exposures in kind of like a controlled setting. So those are the dietitian responsibilities in day treatment. In nutrition group, we are doing a lot of like diet culture debunking. We're doing like nutrition 101, like trivia. We're, you know, talking about, I mean, we're educating them on like TDEE and basal metabolic rate, and, you know, what are the vitamin deficiencies that you experience when you have an eating disorder, all kinds of stuff, right? So that group is a lot of fun, especially if you like nutrition education and especially like diet culture debunking, myth debunking. We have a lot of fun in that group. And then other weekly tasks that are kind of like in the background. I grocery shop for the clients weekly. We have a kitchen here where I provide, you know, a refrigerator and a freezer full of food and a pantry full of snacks for their meal and snack exposures that they can pick from. And typically they're, you know, packaged foods, like more scary foods, right? So that they can really lean into the meal and snack exposures. I'm also looking at their, you know, their weekly weights. I'm looking at what percent of target weight they're at currently, if they're losing weight, if they're gaining weight, if their, you know, meal plan needs to be increased. So all of that is on our nutrition tracking spreadsheet. We're also doing group supervision weekly, which is a really cool aspect of a lot of eating disorder treatment centers, is the clinical leadership is doing kind of like case management, but also kind of like case conceptions, and you're really building your clinical skills when it comes to eating disorders, when it comes to nutrition therapy, when it comes to like counseling. So we have that weekly. I have that weekly with the vice president of nutrition. And then the therapists have another one, and then we also have a combined one. So there's a lot of supervision. It's not like you start in eating disorders and they're like, okay, great, go. It's a lot of team work and case coordination and case conceptualization. And so it's really cool. And then, of course, we have client rounds weekly where we're going over every single client and collaborating as a team between the dietitians and the therapists and the clinical directors. So that is kind of like what my job looks like. And then lastly, I wanted to talk about like what is nutrition therapy when it comes to eating disorders. We know what medical nutrition therapy is. Our DPDs really prepare us to be clinical dietitians predominantly. But nutrition therapy for eating disorders is like a whole nother ballgame. So this is kind of where that, the food and body image and more counseling therapeutic language comes into play, which we don't get trained on outside of motivational interviewing. And so this was really something that I had to do on my own in my own work and also like learning on the job from the therapists that I work with. So from a nutrition standpoint, like we're really looking at meal plan completion. So in their meal and snack exposures, we have people in staff eating with them. They're marking down table behaviors that they're observing from the client. They're marking down if they finished 80% of their meal, 80% of their snack, if they restricted, if they had to complete with supplement. So like an Ensure, boost, stuff like that. So in residential, we're looking for 100% completion of daily meal plan through either food or supplementation. We are typically not doing tube feeds in residential. Some companies will, like the Eating Recovery Center in Denver, where I interned. They did have clients who were tube fed and in residential. Typically, that's an inpatient level of care, but I digress. And then in day treatment, we're looking at 100% meal plan completion with food only. So we are no longer supplementing. We do a food first approach in day treatment because in daily life, we are not supplementing typically. We are eating food, right? And then really what I concentrate on as a dietitian with eating disorder clients is we're working on distress tolerance with fear foods. Of course, nutrition therapy is going to differ client to client, disorder to disorder. But typically, we're looking at distress tolerance with fear foods. So we're looking at food exposures. Are they doing food exposures on their own outside of program? Are they expanding their list of accepted foods? Are they challenging those fear foods? Are they, building an all foods fit mindset? Are they challenging their rigidity and their judgments around food? And are they prioritizing getting enough every day versus like balanced meals, right? We're really looking at making sure that clients are getting enough rather than like, you've got your protein, you've got your carb, you've got your whatever. We're not really looking at that. We're really looking at getting enough rather than being perfect and making balanced meals. That kind of comes in the outpatient work, right? We're also looking at, are they decreasing their use of adverse or like compensatory behaviors? Are they, do they have decreased body image distress? We're doing things like mirror exposures. We're doing things like clothing exposures because their bodies are changing as they're weight restoring. We have scale smashing here. We do all kinds of things like that to decrease body image distress. We have body image groups, and we're really looking towards are they becoming more body neutral or body positive, right? And then we're making sure that like clients are kind of demonstrating, okay, they are challenging their perfectionism tendencies. We see a lot of like perfectionism tendencies in eating disorders. And so we want to make sure that they're building coping skills and life skills that are flexible that challenge their eating disorder rules, their eating disorder guidelines, rituals, values, whatever, what have you. And, you know, are they demonstrating meal plan completion and portioning outside of program that is like flexible, fits within their lifestyle, fits within their schedule? Are they using neutral language around food and body? Are they re-engaging in the activities that they enjoy that the eating disorder took away from them? Are they, you know, engaging in joyful movement that doesn't feel unhealthy or compensatory? So these are all the things that like encompass what a dietitian and eating disorder treatment is looking for. And, you know, it's a lot of it is not stuff we learn in our DPD. So, yeah, I just think that we should have more concentration. If we're talking about, you know, us being nutrition experts, then we should also be experts in the disorders of nutrition, right? So that's just my little tidbit. But that is kind of the whole journey that I took towards becoming an eating disorder dietitian. And I've been at this for 6 months and I really, really enjoy it. One thing I do miss is doing tube feeds and TPN. So I think going into an inpatient level of care so that I can do those again would be great. Because I miss using my science brain as much as I did in my master's in DPD program. So yeah, that is it. Thank you guys for listening. I know that was kind of long. And if y'all have any questions, I'd be happy to answer them. Yeah.
Okay, one question.
Who teaches like the cooking classes? Like, do you teach it, or do they have somebody else teach that?
The question was who teaches the cooking classes for the people?
Oh, who teaches the cooking class? So the cooking class is the dietitian. So, and also sometimes we'll have a chef. So like at the residential facility, there's a chef that I partner with to do the cooking class.
All right, thank you so much, Mia. We'll send the slide.
Of course. My pleasure. If y'all have any questions, you guys can send them to me. Aline has my email address. And if you guys are interested in the Sodexo internship or anything like that, I can send that along too. But other than that, it was really great to share this with you guys. Thank you so much for your time.
Thank you.
Okay.
Okay, so everybody, it is February 18th, and next month is March, which is National Nutrition Month. So we need your ideas. The theme this year is Food Connects Us. And so if you'll have any ideas to share after the meeting, y'all can come talk to me or y'all can send us an email. We really appreciate y'all being as active as y'all are willing to. In past years, we did Instagram takeovers. So if anyone's interested in that, you just kind of share like a day in your life as a nutrition student. And then you can get more information on what this month is about through eBay. So there's 4 weeks of it. The first week's theme is Connect with Food. So this is about learning cooking, food preparation, and meal planning skills, exploring where your food comes from, and learning about community resources like SNAP, WIC, and local food banks. And then week 2 is about connecting with an expert. So you're going to ask your doctor for a referral to an LDN, and then find one who specializes in your unique needs. And then week 3 is about exploring the connection between food and culture. So experimenting with different ingredients that align with your culture. And then week 4 is building the connection across all stages of life. So learning how nutrition should be like our nutrition class kind of, and how to incorporate that and focusing on balance and sustainable eating habits. So if any of y'all want to help us run Instagram or anything, please let us know. Don't be shy. So also at the end of March, we have our running for our future executive board members. So Max is our president-elect right now, so she's going to be president, but we're going to have an open president-elect, which you're president-elect for a year, like vice president, and then you become president the year after. And then secretary and treasurer are also our main spots. Pause. Okay.
You're flying through that. Okay, so important stuff about board stuff. If you want to be president-elect, you have to be either a freshman or sophomore right now. So you have to have 2 years left after this year, so you can serve in both of those capacities as president-elect and president. And then the other two, treasurer, secretary, can be in. Just want to make that clear.
And then you can also nominate yourself, or can they nominate other people?
Usually people nominate themselves.
Yeah.
Send me a picture. Well, I say me. I answer the SNDA email.
Yes.
You're sending me a photo and you're giving like a paragraph of like, this is why I should be insert position here.
Yeah.
And then we put that together for when we send out the ballot. Like we'll have little links. People can click on it, look at your picture, read your thing, decide if they want to vote.
Yes, I highly recommend y'all run because the year I ran for president-elect, I was unopposed. So now I'm president. So this nomination deadline is Friday, March 14th. So mark your calendar. All right, and then our die-cast scholarship recipients are Cameron and Cassandra. So congrats. Oh wait, yeah, one's here. Cameron's here. Okay, so then I got a discount code if any of y'all are trying to go to med school from Med School Bro. He was so kind to give me a discount code. It's Corinne 17 607. So you get 15% off of all of their med school resources. And then our chair reports for February. So we have our volunteer opportunities. You can still check out the Canva document for some different opportunities, and then make sure you log your points and take pictures so you post. And then we have Ag Magic March 24th through the 28th. So you can sign up for volunteer there. And then land is going to be Friday, March 21st and March 28th on Zoom. It's only $19 for students to attend both days this year. And then if y'all are interested in Tiger mentoring, my mentor came back to visit Donovan. So if y'all are interested, it's a great opportunity to either be a mentor or a mentee. So y'all can email Morgan Green and beg her to bring this back. So
It's not a thing this year.
nobody really wants to. Like,
Participation
if anyone wants me to be their mentor, y'all have one more year next year. So
It was fun. It was a good
yeah,
program.
it was
I
fun.
enjoyed it.
And then we have some merch left, limited edition vintage merch. We need to sell it all before making new merch, so it's another motivating factor. You can Venmo us or email Dr. McKinley. The shirts are $5 right now, and then the sweatshirts are $20. We have all sizes left.
I have like one random sweatshirt, and then I don't know what's in that box. So
Alright.
random stuff.
And then our member of the month is did you put a picture of her?
I can't find a picture of her anywhere. She's the hardest person to find a picture of.
How do I pronounce Aja?
Asia.
Asia. Is she here?
So we'll get a picture for the social media.
And then our March meeting is to be determined in April, and then we're done. But yeah, stay tuned. And then make sure you follow us on social media. All right, well, stop working. So also you can still join for spring. It's $12. You can Venmo us your money. So that one you can remember this semester. And then last I have free coupons that Feel Good Food sent me for gluten-free goodie. And so y'all can take one. But it's up to $13. So, yeah. All right, that's it.